coming to other components of management of heart failure, I'll go in brief first with SGLT2 inhibitors, and we know the multiple ways this molecule can benefit both in heart failure and in chronic kidney disease and in cardiorenal syndrome. And I must say we are still evolving various other mechanisms through which this molecule can help our patients in cardiorenal syndrome. So we have a lot of study started with Credence, which took only diabetic kidney disease, but later DAPA CKD and EMPA CKD. This study is so good, so close to my heart, because they open a Pandora box so that I can use this molecule in my non-diabetic patient as well. So a diabetic drug was evaluated in a study population where non-diabetic patients numbers scores over diabetic patients. So this EMPA CKD study, they have 55% of patients population is non-diabetic. So that is the important. And both these studies shows the robust data regarding the use of this molecule even in non-diabetic patients. So this is a DAPA CKD study where almost 1/3 of population of this study is non-diabetic, and whether it's a primary composite outcome, secondary composite kidney outcomes, whether it's a composite cardiovascular outcomes or death from any cause, all the population has robust benefit. Those cohort who received this dapagliflozin as compared to placebo. Another molecule that is finerenone, this is non-steroidal mineralocorticoid receptor antagonist. We have two large studies, Fidelio DKD and Figaro DKD, and they involve almost 12 to 30,000 of patients. And look at their result. The median follow-up period is 2.5 years, and hazard ratio is 0.82. So there is a 18% relative risk reduction of primary composite endpoint like kidney failure with more than 40% decrease in eGFR over 4 weeks period, or death from renal disease. And hazard ratio is 0.86, meaning by 14% relative risk reduction with secondary composite outcome like death from cardiovascular cause or hospitalization for any cause. And based on these two studies, especially in patients with chronic kidney disease and type 2 diabetes, treatment with finerenone resulted in lower risk of CKD progression and cardiovascular events with placebo. They even decrease your urinary albumin creatinine ratio as well. And we know the correlation of urinary albumin creatinine ratio with your endothelial dysfunction leading to the various cardiovascular disease. So based upon this, there is a consensus statement from India on the renal benefits of ARNI, SGLT2 inhibitors, and bisoprolol in chronic kidney disease. And they said that this ARNI, SGLT2 inhibitors, and bisoprolol reduce the neurohormonal activity in several shared pathways and have enormous cardiorenal metabolic benefits across chronic kidney disease patients with or without concomitant heart failure, diabetes, and hypertension. This is published in JAPI, the Journal of Association of Physicians of India. And here are the relative indications where we can use this ARNI, SGLT2 inhibitors, and bisoprolol. We all know, I am not going to repeat this, we had seen in my previous slide. And here is the management of heart failure across the spectrum of chronic kidney disease. So patients with HFrEF with stage 3 or more of chronic kidney disease, meaning by ejection fraction less than 40%. So what we can do, we can give diuretics for decongestion, and we can start with quadruple therapy like ARNI plus beta blocker plus SGLT2 inhibitors plus mineralocorticoid receptor antagonist, and follow the heart failure clinical practice guidelines for device-based or class 2 recommendations. Now, those patients who have MRF with CKD stage more than 3, meaning by ejection fraction between 40 to 50%, what we can offer to our patients apart from lifestyle therapy, blood pressure and lipid and glucose control, we can give diuretics for decongestion, we can add SGLT2 inhibitors, and even if patient is having heart failure, we can add ARNI, beta blocker, or mineralocorticoid receptor antagonist. But if patient is with heart failure with preserved ejection fraction, that is HFpEF patient with chronic kidney disease, CKD stage 3 or more, and ejection fraction more than or equal to 50%. So apart from diuretics, we can give SGLT2 inhibitors, plus we can consider for ARNI or MRAs. Now, the take-home message for my talk, that combination of heart failure and CKD chronic kidney disease is common. Cardiorenal syndrome has worse prognosis. They not only increases the morbidity, economical burden, but the incidence of mortality is quite high. If GFR is more than 30, treatment is according to guideline. But if GFR is less than 30, there should be a collaboration of cardiologists and nephrologists. And with new potassium binders, we can use those molecules, which is quite worrisome in past. The trajectory of chronic kidney disease can be slowed down by RAS inhibition, ARNI, and use of SGLT2 inhibitor. CKD detection and treatment saves the heart. And this heart failure and CKD should never be treated alone, because there is a close connect between heart failure and CKD, chronic kidney disease, and this cardiorenal continuum should be treated as a whole. So that's all from my side. Thank you for your patience hearing.